of this SBIRT for Youth learning community, Dr. Hagel, Dr. Harris, and Dr. McPherson. Just some information there. We actually do have a different speaker today, so I will move along just to some additional information. I just want to cover some information about the National SBIRT ATTC. We're funded to advance SBIRT as a timely public health model, and we offer a suite of services, and we have a nice list of the information here. This will be available in the PowerPoint after the fact. One thing we do want to highlight as far as those existing resources is that they live on the website, the ATTC website. It looks a bit like this. And you will also find information about our online courses. We do have a self-paced online course on SBIRT for adolescents right now that is always open. That's a 24/7 that you can create an account and log in to go through that course, and you can earn 3 CEUs through that course. So it would be a good option if you were looking for something additional. Now, as far as the learning community itself, I just want to run through as far as the goals. The learning community will focus on the process of SBIRT as it is being implemented for youth audiences, examining the application of SBIRT in various youth settings, create a community of providers, administrators, and researchers who share a passion for reducing and/or eliminating substance use in youth populations, and share experiences with implementing SBIRT in youth settings. Now, this webinar in particular is a time where we'll be sharing some experiences. There's just a little bit of additional information about what we offer with the learning community. Bi-monthly meetings, you'll get more information about that shortly, and a web page with information. We also have technical assistance, so if you have any questions about support for implementation, coaching, and troubleshooting, you can email us at sbirt@attcnetwork.org. Okay. We have some additional information as far as why we see this as so valuable to care about screening and intervening early for youth, as far as adolescence being the last stop before adulthood and addiction having an early onset. And just some information about the most promising sites to identify youth needing but not receiving SUD treatment. Great. Now today, this webinar is about a featured program, and our presenter is Dr. Tosan Oruwariye. She completed her internship and residency at Montefiore Hospital, obtaining a master's in public health from Yale University, and completed training in preventive medicine at the Mount Sinai School of Medicine. Dr. O has practiced as a primary care pediatrician at Montefiore Hospital, where she developed her interest in primary care research and school health. She obtained a master's in clinical research at Albert Einstein College of Medicine and continued her interest in school health as the medical director of community-based services at Morris Heights Health Center, and is an assistant clinical professor of clinical pediatrics at the Albert Einstein College of Medicine, where she continues to teach in precept medical students and residents. Dr. O, as the Chief Medical Officer at Morris Heights Health Center, is interested in adolescent reproductive health, alcohol and substance use in youth, and has been involved in school health research with various abstracts and publications. She is a member of New York City Child Fatality Review Committee and the Public Health Association of NYC. More recently, Dr. O has been involved in healthcare innovation and business efficiency in primary care. Now at this time, we're quite grateful to have Dr. O to speak today. I'm going to pass things over if she is ready, and she can start her presentation.
Hi, hello, good afternoon.
We can hear you, Dr. O.
Everybody hear me? Okay.
Yes.
Okay, I'm going to show my screen now. Can everybody see my screen?
Yes, we can.
Hello, everybody. Good afternoon, and welcome to my presentation today. I have nothing to disclose, and I felt I should tell our story because we came from a different perspective in Morris Heights Health Center, and we had a different approach. So my objective is really to share our experiences in the implementation of SBIRT in our school-based health centers in the Bronx. And I'll give you a little bit of a background about Morris Heights Health Center. We're a federally qualified health center, and we have about 17 school-based health centers with over 17,000 students. And we offer a mix of comprehensive primary care services that include primary care, GYN care, and dental care. We are staffed by medical providers, social workers, and health educators, and these services are provided at no cost to the students. The goal is really to improve access to care. So our journey started in 2008 when we opened a new school-based health center in a certain part of the Bronx, because all our schools are in the Bronx. And we've integrated routine screening into primary care. We noted that the responses to 4 questions on our surveys, these are adolescent surveys, that assessed alcohol and drug use of patients and their friends were very high. So we reviewed the charts over a 3-month period, and we found that 60% of the teenagers we were seeing had a positive response to these questions. The questions were, in the past month, did you or your close friends get drunk or very high on beer, wine, or other alcohol? And the other question was, did you or your close friends ever use marijuana or other drugs or sniff inhalants? So 60% was really stunning for us. We had never seen that in our other school clinics. And we didn't know what to do with that information. In the first 2 weeks of opening that school health center, we realized there were a lot of unhealthy behaviors going on. Many students were coming in either with bruises on their different parts of their body. The girls were telling us stories of being rough handled by the boys in the schools. Many of them had high absenteeism, but were coming in late. We're not sure what was going on, so we acknowledged there was a problem with substance use. And we acknowledged that we didn't know anything about this. We needed skills, and we needed to learn more about what was going on. And the teachers in the school also shared with us, they were worried about substance use impacting the learning of the students. So what did we do next? We set up a team. We presented the issues to the clinical directors, and we said, who's going to handle this project? We had a team of a clinician, a health educator, but the clinician started first. We said, let's look at what's offered there for teenagers. We didn't know anything about SBIRT at this time. And the clinician came back and said, you know, there's this program called SBIRT, and they use something called the craft. And we told the team to read about it and present it at our monthly meetings to the whole group, and see if it was something we wanted to do or we could implement in our current setting. So that's how our journey started. It was really clinician-driven, based on patient care. Nobody came in to tell us you have to do this. So I suppose for us, that was why there was an interest, because we saw this day in, day out at our clinic, and we didn't really know what to do about it. So we learned that alcohol is the most commonly used drug among teenagers, and it starts in 8th grade with about 80% of 12th graders reporting alcohol use. We also learned that it was very morbid, and it caused a lot of the morbidity we're seeing in that school. What we saw was really their academic and social problems and the infections and pregnancies from unplanned, unprotected sex that went on in this high school due to alcohol, always related with alcohol. We learned the kind of parties the students had and what went on in those parties. So we realized that it was something we had to do. And We also learned that we could talk to the students, because one of the things the school health program offered was confidentiality. The students could come into the school setting, they could talk about these problems, and they actually shared a lot of information with us. Some we wanted to hear and some we didn't want to hear about what went on in their communities. They told us about alcohol parties. We found out how they bought the alcohol, who buys it for them, as well as other drugs, how it's shared. And for us, it was a new arena because we're just clinicians and we never knew this went on at all. And when we found out in that school, we then asked our other clinicians at our other high schools, you know, are you seeing any of this? Their percentages of response to those questions were low. But when they did focus groups in those schools, they found that the same issues were happening, the same high-risk behaviors, and the same impact of alcohol and substance use was also happening there, even though there were smaller numbers of patients involved. So we said we really had to screen in more details, and we felt that it's a marker for other unhealthy behaviors, and it's usually the first substance abused by the teenagers. And when we chose brief intervention, we learned that it's a good way to address teenagers because their problems are not as complex at this stage. And this person-centered approach that SBIRT offers is very appealing to young people. But because of their short attention span, this commitment is not lengthy and is not intensive, which is usually difficult for this age group. And we also learned that it could be used at different settings where youth are seen. So the first thing we did was to train our staff on adolescent confidentiality according to the New York State law. We learned about teenage rights as it concerned alcohol and substance use, because some questions were raised when our staff met to say, how do we tackle these problems? We're going to refer them based on their risk to centers for treatment. Do we engage the families? If we engage the families, will the students trust us to come back to get care and continue care? So we first of all got expertise by the New York City Civil Liberties Union. They came to give us a talk about our teenagers, their rights, and how to actually address the contents of substance use in the context of the New York State law. We also realized that we should just not screen for alcohol and substance use, but that to be really impactful, we should screen for other high-risk behaviors that is associated with these students, and we started to do that as well. We then decided to do a focus group. We did focused interviews, and we engaged the school communities. We engaged the counselors, the principals, detailed interviews on possible ways to address the issue. We found that it was really pervasive, and although we were targeting 8th graders, we found that 6th graders were also binge drinking and missing school. Law enforcement was really involved in this school. So we started from the ground up trying to figure out how do we create a program in the context of so much chaos. So at that time, as we were exploring what to do, we had reached out to our city council to share the preliminary chart review data. To say this is a problem in this school. We got buy-in from the principals, the assistant principals, and we could document the absenteeism, the missed class, the law enforcement being called every week to the school, and really made a pitch that we needed some funding to start a pilot project in this school. And we did receive this funding, about $40,000. When we got this funding, the city gave us some deliverables, and they wanted to see that these monies were well used. And we created a deliverable and a timeline, and it was, I think, an 18-month timeline to implement this pilot and this project. And the first thing we did was to obtain training for SBIRT. And we decided to train everybody in the school setting, because in the school-based health center, the first person could be a receptionist, and we needed to make sure they're aware of how a young person might come in drunk, or have a concern about substance use to refer them to the appropriate staff within the clinic. There's usually three people in the clinic: the clinician, the social worker, and sometimes the health educator. So everybody was trained on SBIRT. And we got training from the New York State OASIS team. We also then got another 2-day training on Teen Intervene. And this was also offered to us by the New York City Department of Health. So the first thing we focused on was education on the staff, on what works to address this condition and the different strategies involved. It was very important because the two trainings had slightly different approaches. The Teen Intervene involved the parents, but the SBIRT didn't always involve the parent. And we had to decide which one will we use in this setting. And that was a lot of discussion with the team we had set up and with the school authorities in that school. So we decided to select 2 sites. We developed an actual implementation team. We had a clinical champion. And as I mentioned, we defined deliverables. Because it was a school-wide problem that was so pervasive, we felt we should do classroom presentations to educate the young people about substance use that included alcohol, marijuana, inhalants. We actually learned they were doing so many different kind of, using so many different kind of substances in very risky ways, from putting alcohol in their eye to really high-risk behaviors to get high. So we decided to do these classroom presentations. They were structured. The principal gave us 45 minutes, and we did this over a 9-month period. We also decided to screen the students as they came in. And although the deliverables set by the New York City Council was about 200 students must be screened in the time frame, we screened a lot more students because we had integrated it into our workflow in the clinics. We also included substance use as a topic for our health fairs because we are required to do health fairs in all our schools every year to further educate the community. So some considerations for the implementation team as we thought about this. We thought about the meeting dates. When do we want to do this? When do we want to do this screening? When do we want to see these kids if we identify them? Do we involve the parents? Do we involve the parents? What are the implications for that? Do we use incentives? Because we worry that these students might not come back. For them to be treated based on their risk classification, they have to have at least 4 interventions with the health educator or the staff providing the intervention. Will they come back? If we use the incentives, is that enough motivation? Will we say they're really ready to change? And then we have to think of what screening tools should we use. We have the choice of the craft, the assist, the audit, the DAS. Which is easier? Do we do a self-report? Do we let the student administer the interview? Or do we get the clinician to take the information? Do we use this as a standalone tool? So when the patient comes into the clinic, we just give them the craft tool? Or do we give them with other tools we use in their care? And do we expand this screening opportunities at all visits? Because traditionally we only did it when they come for their well child visits. Do we do that for all routine visits? What kind of impact will it have on our clinic flow? What kind of resources do we need? Usually when the students come into the clinics, they don't want them to spend more than a period. That's 55 minutes, so they don't miss so much school. If they decide to complete this form, will it take more time? So we had a lot of questions to ask as we said to think about this pilot. So in preparing for that, we went back again to the school to say, you know what, we have reviewed the confidentiality law. This is what we want to do. We looked at the curriculum on alcohol and substance use and asked the city in the school, what kind of health education topics do they talk about? We found that there was very minimal information in the school curriculum. They had talked a lot more about HIV and pregnancy and sexually transmitted disease, but very little on alcohol and substance use. Because we had engaged the school community, they were open to the idea of having something about alcohol and substance use routinely offered when they when they did the health education classes. We also looked at what kind of tool to collect, the data collection. We had to create surveys, we had to look at our clinic workflow. This data collection, who's going to assess it? Remember, we're not many people. We're just 3 or 4 people in a clinic. Who's going to assess the data, analyze the data? And this was a pilot. There was a lot of burden on the staff, considering all we wanted to do was to fix this problem. We realized that we needed educational materials targeted to youth. I remember when I referred one of the young gentlemen to a risk reduction clinic, the first thing he came back to say, he said, "Doctor, I'm not a junkie." So we realized that most of the services were for older substance users, and there was nothing there. There were very few facilities that catered to youth. So we had to look at what community resources was out there. How can we facilitate referrals if we needed to facilitate referrals? The kind of educational materials we needed, we had to get ones that were targeted at youth, that was simple enough for them to understand. We had to really develop those linkages, because when you had 1 or 2 students that really wanted to go, wanted to make sure they could get in quickly. And a big part of it was, how can we pay for this? We are paid to see patients and care for patients. This was something that affected our work, but how do we get reimbursed for this? So a lot of things we had to learn about as we decided to implement this in our school center. So one of the things we first decided was to, since it was a pilot, was to use the PDSA methodology to track everything we do. So we will meet, we'll have a plan, every week we'll review it, and if it's not working, we'll tweak it. If something didn't work, we'll act on it. And that really helped us to implement, track, and assess the ongoing progress of what we did. As you can see, it was a lot of work, considering all we wanted to do was to learn about how to care for these students. But since we had gotten funding for it, we felt some of those funds could be used in areas like this to help us track and assess what we wanted to do. So with the successful outreach to the school community, we felt they were more open to seeing the data we could share. And so all the work we did, we actually shared it with the school authorities in terms of the data, and to see the impact of what we're doing. And it really helped us in promoting the service. The school substance use counselors who were already in the school but couldn't engage these kids were now engaged. They actually shared with us some of their challenges. They shared with us some of their strategies, and we really worked well as a team. And the school actually planned a substance use fair dedicated to substance use, where we actually got community agencies like Daytop, this is in the New York area, to come in to talk to the kids about it. We had former teenage substance users come in and talk to the students about it. So we felt the funding from the pilot really made us do a little bit more outreach and help us with the data collection. So as we continued doing this work, we had a lot of interest by other agencies. The city came by to see what we're doing, and the state also came by and initiated a conference call to understand what we were doing and to address some of the issues we had talked about in terms of billing and sustainability. They paid a site visit to us, a clinic site visit, an administrative site visit. They wanted to work more with us on a statewide pilot, and they discussed more about tool selection and data collection and evaluation. And they facilitated other outreach to other agencies. So this project we started really started to evolve and become a bigger community and citywide project. So we decided to use the craft. So we first of all decided to call the program the ASAP program. We named it. We selected the craft after we reviewed all the different questions there. And then we decided to offer this screening tool to at all visit types. So whenever any of the students came by, we'll offer them this screening tool. And we integrate it into the workflow with other screening tools. So we didn't want to select out this tool. So we had tools that looked at nutrition, and we included it in all our standard tools that looked at depression, the PHQ-9. So this craft was integrated into our other tool. But what we realized was that if we selected out a tool for substance use, the students felt very, very self-conscious. We had a workflow that any positive screen we had was referred to either the social worker or the health educator for further assessment and brief intervention. We then used the assist to further assess and capture the level of risk for the students to decide if we're going to intervene there or need to be referred out. So this was how we classified our risk level and what we could do. So if the students were low to moderate risk, we used the NIAA standard, the National Association, the youth standards that helped us decide the different levels of risk. And we offered these 4 brief intervention sessions. And then we went through the behavioral change concept and model, and we documented the change in behaviors. And actually, we did have success with students that identified their goals, that chose that were ready to change, that were confident they could change. We used all the confidence ruler, the readiness ruler, all those tools we used, and we actually did find success in some of the students. So we had this categorization, and I will say most of the students fell into the low to moderate risk, like the literature affirmed. And we only had 2 students that we had to refer out that were dependent and addicted on not just alcohol and marijuana, but other kinds of substance use. But still, what really surprised us was with the low and moderate risk, the impact on schoolwork and academic outcomes was really devastating. So it didn't matter just the risk level, but just participating in these high-risk behaviors has such consequences for the youths in the school. So when we talk about the brief intervention, we said we'll use the standalone approach with the low to medium risk teens as a prelude to participate in more extensive treatment. Why we wanted to do this, because we felt that, one, for that group it was appropriate and it could bridge some time for them pending when we could refer them out. We also felt that we found that for the youths in that school, they could come for the 1 or 2 treatments, but after the 3rd and the 4th visit, they didn't come as much. So we actually saw a dip as we intervened with these students. Very few completed the 4 interventions required for the low and medium risk group. Most of them did 3, and that's when we thought about the incentives to see they'll complete all the sessions. So what did we see? So we reached over, with our classroom presentations, we reached over 1,000 students. We exceeded our deliverables. And we got very engaged students that talked about it. It was interesting what the students shared about the impact of substance use. And we're very welcoming to the idea. We had students come up to say, oh, miss, we didn't know that it was so bad. Well, we didn't know that this could happen to us if we did that. So there were a lot of them were engaged because it was a forum for the youths, and we had young substance use youths talk to the students about the impact of substance use. So this is just a visual, and the 2 schools we used as a pilot of the number of classroom presentations. So we found that even within the schools there were differences. In one of the highest risk schools, we call School A, we found that 24% screened positive, which is higher than the national average of about 12%. In the other school, there was 13.5% positivity rate. And still, those are high numbers for youths in the school. So in this school, like a quarter of the students were using substances. You can imagine that was the school we went into and discovered such chaos. And the school was really, really willing to work. And while we're there, we didn't just have the substance use program, it actually involved law enforcement, and law enforcement came in just to manage the chaos, which was primarily due to a lot of substance use and fights in this school at that time. So we did over 250 screenings using the craft. And of the 25 students who screened positive, 15 of them came back for at least one session of brief intervention. Not as much as I would like. And as I said, as we followed the students down, I think only 3 did the whole 4 visits we had planned. But we had a total of 41 sessions with an average of 2.7 sessions per participant. We wanted at least 4 sessions for the brief intervention. In the other school, of the 20 students, all came back for 1 intervention, but they also tapered down, and after 48 sessions, we had about 2.4 sessions per participant. This is just a schematic of that. Those that were positive and those that came back. So even with the incentive, we still found that not all the students came back, even though they verbalized they wanted help. So we learned that we needed to find other modalities, and we thought we had to include brief intervention into clinical practice. Rather than just come to see the health educator for the brief intervention, we really ramped up the training of the clinicians. So when they saw the patient, they could include that brief intervention into the care of when they saw the patient. And we felt that would have yielded more of a result for us in terms of behavior change. So in the first school, 6 students came back for the brief treatment, which is another 4 sessions, separate from the brief intervention. As I said, you had a brief treatment when you were at a moderate risk. And for those 6 students, they had a total of 17 sessions, making it 2.8 sessions per student. And for the other school, they only had an average of 1 session per student. For the other school, they didn't have as much students, they didn't have as much incidence of positive screens as the first school. And this is just a schematic of that. As I mentioned, we had a huge health fair. We kept on using opportunities within the school to engage the other students. We had I won't say they were peers because most of them were not substance use, but we got teens to learn about how to talk to their peers about reducing substance use, and they were like teen champions within their schools. And we had different strategies just to increase the awareness in that school. So one of the big areas was reimbursement, because as we were doing all this work, the organization was very concerned about us maintaining our productivity as clinicians and getting paid for the work we were doing. They shared with us the code, and one thing we learned was that other providers could provide SBIRT services. And they had different training requirements, other ancillary providers. So we made a conscious effort to train our other ancillary providers and learned all about the different rates with the hospitals, with the APG rates, and the fee-for-service rates. A lot of detail in terms of billing, but it was very, very important for our organization to make sure we're reimbursed for this time. Because you can see, this takes a lot of time and effort. So what did we learn? We learned that we really need to track using the PDSA more consistently. When we started the project, we just wanted to find out really how to help the students. But for anything new, there were so many variables, so many people. How do you bring the kids to the classroom? Who sends them back? The confidentiality. If you find them drunk, do you tell the school? Do you call the parents if they're out of it? There were so many variables, and we needed to really make like a checklist and really look in detail about what to do and how to track it more consistently. And this was a challenge in a busy practice. We have one clinician there, and these kids are coming in and out, about 25 kids seen every day. And when during the day do you have somebody to do this and integrate this without needing to hire more staff? So we found out we didn't always screen them consistently, though we had said we wanted to do that. And we couldn't really track the kids when they were coming for the brief intervention versus the brief treatment. So sometimes it was all jumbled for the staff, and how to bring them back during the school day. So the logistics was very difficult. And we felt we needed a full-time person in every school, in that school in particular, to really run this program, support it, bring the kids. Especially in schools like that, you have, this school had over 1,000 students, and with over 200 and almost 300 students with positive screens, we felt it was enough to get somebody dedicated to address this problem. We also found that the incentives didn't always work. Sometimes it worked for some people, and sometimes it didn't work. And so really reviewing every piece of what worked, what didn't work, and why did it work for some and why didn't it work for some was so important for any sort of long-term sustainability to this program. So I'll talk briefly about this because this is where we now got into this official pilot by the state. Because now when the state came on board, they wanted us to do a little bit more. They wanted to look at the attitudes of the students. They revisited the evaluation tools. They changed the deliverable. They wanted more schools included. And they revised a bit of the workflow and how we did the students' engagement. But I will say that the most important thing for us was really going back to the basics and saying, you know, why did we want to see these kids? We found that it was really very, very important to look at your setting, because once we expanded to other schools, we found that each school is different. Not all the schools had the same issues. Not all the schools had the same principals that were engaged. Not all the clinicians were that engaged to, you know, focus on this issue, because one of the problem for them, as it was for the other group of clinicians in this setting. So really know your setting. Know your setting is very, very important. We use focus groups a lot to see what will work going forward, what will work for you, and be open about tweaking, refining. We felt for you to start it, you need a small team to see what will work for you, who will do this. And if it's in a school setting, you really have to get the principal, the buy-in, the security in the school. We live in New York, they all have security in their schools. It was very, very important. The training was the most important, because when we got trained, we didn't just get trained on substance use. We got trained on motivational interviewing, and those skills are transferable. And I think that was the greatest benefit, because those skills were used not just for substance use, they were used for obesity management, for chronic care diseases. So getting the appropriate training, reinforcing the training was so important. We got trained every year, and we've included training like that into our yearly training for our staff. Using the tools are so important. Some of the tools are so complex for a clinic and for that population. It might take so much of your time to complete it when the yield might not be that high. So looking at the tools you use, need to be simple for the staff to use. You can easily see what's going on was also very important to us. And developing a plan. We had a plan that we had a conference call every 2 weeks to see how it was going. We reviewed our workflow, and we constantly evaluated. And even then, I could tell you it was a challenge to implement this program. It was very new for us as clinicians. But I'll come back to the first statement I made. For us, it was really trying to solve the problem and looking at ways to solve the problem that really drove the clinicians in that setting. And once we started that process, we realized this was something that was going on all around us, but we hadn't even identified it. And then getting the stakeholders involved really supported us to implement this with the state, the city, another people that had expertise in that. So reaching out to those stakeholders within your community outside that have expertise was also very, very important. So I was going to acknowledge in this email some of the state and city agencies that have helped us throughout this, that arranged all the trainings and came to support us through this project. So I'll talk a little bit about the Year 2 project that happened in the other schools. So we expanded this project, and I will say we didn't have as much oversight in Year 2 as we did in Year 1. One of the things we realized was it wasn't the same level of, it wasn't an issue in every school. Depends on the area the school was located. So that sense of urgency wasn't there with the other schools. We also did not have the funding in Year 2 to track the data and follow through like we did the first year. So we realized you need somebody to really do that kind of intense work to implement that program. And we needed to find a way to make it easy to integrate it into the daily workflow of the students. But in the original school, that program is still ongoing. So these are some of the references and some of the resources we used as we searched for information and questions.
All right, great. Thank you, Dr. O. We do have a few questions that came in that I'll read off to you, and we'll go from there. The first one we had is, how do you distinguish brief intervention and brief treatment?
So for brief intervention, we started with the risk categorization. And the risk categorization is based on the amount of alcohol the students use. And we use they have the National Institute of Alcohol Abuse and Alcoholism has a youth guide, a practitioner's guide, which actually tells you, based on the amount of alcohol the kids are taking, who's at a low risk, who's at a high risk, and we use that guide to categorize the students. If they are low, then the intervention is brief. It's really change. I call it change talk. It's still motivational interviewing, and it's just targeted to make them agree to the change, motivate them to change, own it, and then make that decision to stop using substances. But if they are a higher risk, it takes them a longer time. So really it's the same thing, but more intense change talk for the brief treatment. And it's really, they have more sessions, and they take a longer time to decide moving them along that spectrum of change. It's really the risk that helps us decide who gets what.
Great, thank you. Next, when you engage all stakeholders, does that include students and/or parents?
So when we engage the stakeholders, it's really the student. For us, we decided not to go with the parents, because in the school setting, the students are very, very, very adamant about their confidentiality. They don't want their parents there. They see the school-based health center as their own space. So we made that decision not to engage the parents, except the students said they wanted us to do that. Now, as I mentioned, we had two models to choose from. The Teen Intervene, which involved engaging the parents. But in our own setting, based on the focus groups we had with the students, they definitely didn't want their parents there. We also had to decide if the student was at risk to himself, because we had one of the students that really got so sick. And we shared that with the student, that if you come in intoxicated and you're a risk to yourself or to somebody else, and we feel that we'll have to contact your parents, and they were aware of that. But we didn't have to do that for most of these kids.
Okay, great. Next, approximately how long did it take from conceptualization to implementation?
I would say it took us about five to 6 months, because we're just about 4 people, and we have a 9-to-5 job. So once a week we'll meet by conference calls. So what can we do? We'll do the research. They'll come back. It was a slow process. And then when we got the funding, it helped a little bit because we could get some outside resources to help us facilitate some things we wanted to do. But I'll say about 5 to 6 months to actually starting the pilot schools.
Okay, great. Next, what type of certifications were needed for billing purposes?
So in New York City, where we are, we had to take the training, the SBIRT training, and it depends on the ancillary providers. Now, for clinicians like physicians and nurse practitioners, it's 4 hours. For non-clinicians, I think it's 8 hours. They have different hours for different levels of providers and different reimbursement rates. So you have to do that. It has to be a state or city approved training you do, and then it's sent up to the state and is included in your licensure. So when you bill, they will know that you have that certification. But we couldn't bill because, as I said, we found out that we couldn't bill, so that was another challenge for us because we're a federally qualified health center in New York State. And there's a different kind of billing called the APG system, which we could bill under, but we don't have that system of billing. So that was also very challenging for us.
Thank you. Next, what were the primary concerns for school personnel regarding SBIRT?
Well, I think for the first school, I think they were relieved, first of all, that somebody was going to try to do something. It was a new school we had just come into, and they never mentioned that was a concern to them when we opened that clinic. When we shared this concern, they were happy that we're thinking of a solution. We didn't come to them to say, do you have an idea of what to do? We came with a solution that we saw this problem, we've been doing the research about it, and there's something we can do as a team to address this. So we came from the perspective that we all had to work together. And the school already had a substance use counselor that was very ineffective. So the substance use counselor in the school was very happy to have an ally to say, look, I know it's a problem in this school, and I've been trying to get the attention of the leadership. Now we can all go together and we could document with data the number of behaviors we felt were related to substance use and the impact to the principal. And I think coming with the city support as well also made them feel this is something they could help. We also got this law enforcement in the school. There have been major fights where the police come in and into the school, really bad fights in that school. And we'd also gained their own input to say, look, how can we do this with all these fights? And they were also willing to work with us because it wasn't just the intervention. It involved looking at how the students moved around the school. It was really a collaborative effort. There was a problem in that school.
Great, thanks. So the questions keep rolling in. This will have to be one of the last ones, depending upon time. But we have next, overall, how did youth respond to the brief interventions?
I would say very positive. If you work with youth, you know they give, I call it TMI, they give you too much information. They're willing to share. They tell you what you're doing, what they're taking, and we were really alarmed. Some of them really wanted help, but many of them were ambivalent, and we've learned about teenagers. They're not sure what they want to do. They don't really like the behaviors, but they can't make a decision yet. But some could. So we had some that wanted to go to college. They were trying to get a track or a sports scholarship, and they knew to check their urine for substance use. and really helped them focus. So they appreciated the support that we provided through the SBIRT. So many of them, as I said, once they were positive, they'll come for the first session, but they dropped off quickly. And when they come in, they all had a sense that they all felt, I'm not an addict, I can manage this, I can handle this. That was always the first response. Even though we saw them in the clinic for other issues and we reminded them, you missed your appointment for brief intervention, some will say, oh, I'll come back another time. But a few really went through and really were motivated. And that's why we really looked at the program, because we had thought of incentives and we felt it didn't quite work. What will make them work for this group? And we looked at the literature to see, out there in the literature, what sort of compliance or the rest of the population have compared to youth. And we had a higher level of non-compliance than others. And so we were sort of trying to think about how can we do this, better.
Great, thank you. So there were a few questions we didn't get to, but I will circle back around to you, Dr. O, to get those responses, and I'll email those out to everyone. I'm just trying to end towards the end of the hour. So I am going to take back, and I have a few last-minute things to go through. Dr. O, thank you very much for your presentation.
Okay.
I do appreciate that. You should see now my screen. I just want to talk about the next steps for the SBIRT for Youth Learning Community. We are actually looking for some guest presentations. So this would be an opportunity for individuals to share experiences or plans about SBIRT of their own. It would be about 15 minutes. You'll get a chance to explain what you're currently thinking about doing or in the process of doing, and also get an opportunity to ask questions about implementation and get answers from the experts and input from your colleagues. So these would be going on over the next few meetings of the learning community. So they would be at the end of September, the end of November, and the end of January. So if you have an interest in this, and we hope you do, what I'm going to do is I chatted out a link to this request. So it's just a quick form you fill out with name, organization, and just a little bit about your project. And we'll go through those and pick some people for guest presentations. I'll also include that link in the follow-up emails. So you'll be receiving from us some information as far as the recording and the PowerPoints to your email after the fact. Those will come out throughout the next few days of this week. Again, I'd want to thank everyone for attending, and Dr. O, thank you very much for your presentation. Did you have any last-minute comments?
No, not at all. I just wanted to say that for us, it's been a rewarding experience as clinicians, just seeing that we could address a problem even though we're not trained, and there are resources out there to know that you could get support when you go to agencies like yours and the city to say, look, we have this problem, but just be mindful so you're not overwhelmed, because we were a little bit overwhelmed and trying to get as much support. And there is support out there, and the teenagers need it.
Certainly, certainly. Well, thank you so much for taking the time to be with us today, for presenting, and I hope everybody has a good afternoon. Okay, thank you.